Good afternoon. My name is Nidhi Madan. I'm one of the second-year fellows at Rush University Medical Center in Chicago. Today, I have the honor of talking with Dr. Jonathon Leipsic at the FSCCT 2018 as part of one of the members at the first committee of the FSCCT. Dr. Jonathon Leipsic is a professor of radiology and cardiology at the University of British Columbia, and it's been our honor to have you here today and talk to us, Dr. Leipsic. I have a few questions that our audience would be interested in knowing from you. The first question I have is, how do you see the CT, cardiac CT, impacting the world of valvular heart disease in this year, 2018?
That's a good question. You know, predicting the future is always difficult. But if we learn from the past, what I know is that over the last decade, we've realized that CT doesn't just play a minor role, it really plays an essential role, not so much in the diagnosis of valvular heart disease, but in the management of valvular heart disease. It augments echo and MR in the diagnosis in complex situations. It's also extremely helpful in the planning of structural heart disease interventions. And also, I think also in post-implant imaging, looking for leaflet thrombosis, infective endocarditis, complications of intervention. I think CT, being an exceptional anatomical test, really provides the totality of anatomical information needed to guide interventions and understand patient-specific risk, and then post-procedural imaging in the setting of complications or increased clinical concerns. So a lot of exciting opportunities, not to mention the opportunities with metabolic imaging and PET-CT and things of that nature to look at issues such as structural valve degeneration and progression of aortic stenosis. So the next decade, I think, will be as rich and as rewarding as the last.
That's a very good point. To that effect, a lot of indications have come up in today's world using cardiac CT in valvular heart disease patients. We would like to know if there is one particular indication that you would say would be having the most impact on the field.
I think when we're looking at valvular disease, I think it would be fair to say that its role in planning intervention is really its strongest role or primary indication. I think CT plays an important role with regards to the adjudication, as I mentioned, of disease processes, things like mitral valve prolapse and adjudicating the nature of mitral regurgitation, evaluating for native infective endocarditis. All of those are important roles. But when you think about the one indication that is almost uniformly or dependent on CT, it's really in planning intervention. So whether that's TAVR, TIMVR, transcatheter tricuspid intervention, obviously echo plays an important role in the determination that there is valve failure or aortic stenosis or mitral insufficiency. But when it comes to mapping the patient-specific risk and defining the landing zone, the annular sizing, and all of these things, I think there's no better test than cardiac CT for that indication.
Yeah. I think that's great. We've talked about the uses of CT in the world of valvular disease. We would also like to see what your thoughts are on any limitations that this technology of CT might have in this particular subset of patients with valvular heart disease.
The limitations are still around temporal resolution. Volume coverage, I think, still poses an issue. Limitations around the ability to image the coronary arteries prior to transcatheter interventions. I think we've moved a long way with higher temporal resolution scanners and whole heart coverage scanners, but I think we need to do better. There's obviously limitations with regards to quantification of flow. We've seen tremendous progress with regards to the integration of computational fluid dynamics in the coronary space, but I think there's real opportunities. People like Ronak Rajani at Guy's and St. Thomas in London, and Elazar Edelman at MIT, and the Brigham looking at CFD and quantifying flow. We saw some excellent presentations earlier looking at 40 flow from MR and the parallels with CT. So I think if we can really engage in not only ventricular contraction and strain, which is we're moving forward with, but also in having an assessment of flow dynamics and then further improvements in temporal resolution to allow more robust coverage of the coronary arteries without rate control, then I think CT will even move forward further with regards to providing the total information that's needed for these patients that are being evaluated for intervention.
I see. Yeah, that would be something
It'd be quite exciting. Yeah.
Yes, definitely.
Yeah.
And last but not the least, I have one question for our fellows and the early career members.
Sure.
You've been a past president at the FSCCT, and we all look up to you for so much that you've done. It's been wonderful to talk to you today. A piece of advice that you would give to our fellows and early career professionals going forward who are aspiring to be into good imagers, good people in CT?
Sure. I think, listen, giving advice about life is a challenging thing because no one has all the answers. I can tell you that for me, engaging with the Society of Cardiac CT was probably the best thing that I could have ever done. It's been so enriching to my career, meeting so many people, young people, senior mentors, people in radiology and cardiology, and it was really tremendous, and it really opened my eyes to what could be. You know, I'm trained in radiology in my background, and while I always took pride in being a strong imager, I didn't really think that I would embark on solving clinically relevant questions the way I have had the opportunity to. And I think the SCCT played a pivotal role in opening my eyes to that opportunity, and rather having a low ceiling thinking, well, my role would be simply to interpret the images, I realized that there was a really exceptional opportunity to affect patient care and engage in these really exciting clinical problems. So I say follow your heart, so to speak, and be passionate and work hard and enjoy the collaboration.
That is important. That's very key.
Yeah, for sure. It's all about collaboration. It should never be about ego. We're not curing cancer here or bringing peace to the earth or anything. We're just trying to improve patient care little by little, learn, share knowledge, and I think enjoy in the experience. So,
absolutely.
Yeah.
It's been wonderful talking to
My
you,
pleasure.
Dr.
Thanks
Leipsic.
for having me.
Of course, and thank you again for joining us today.